All right, welcome to the summer series, CME. I'm going to be giving the lecture Dab Carts and Lost Marys, Teen Substance Use Trends and Primary Care Management Tips. Paul Glazer, I'm a triple boarded, so I'm a pediatrician, adult psychiatrist, and child adolescent psychiatrist. And I work with a lot of teens with substance use issues. And therefore, I'm going to give you not only some of the trends that have been going on lately with teens and drug use, but also just some real practical tips along the way and some, AAP approved interventions for teen substance use that you can put into your primary care clinics and or wherever you practice medicine. For CME purposes, I do not have any disclosures here. Any research funds I get are from the NIH or CDC. And most importantly, I don't receive any money from any big pharma or big weed, I would call it. There's now a really big money set of corporations that are promoting weed across, marijuana, cannabis across the country, and I do not receive any money from them. Our objectives are here for those of you going for CME credits. All right, where did I get all of my experiences? Well, Children's Hospital in St. Louis hired me about 8 years ago to head up teen substance use treatment, especially the psychiatric care of these patients. It initially was through Bridgeway, but I quickly merged with Bridgeway with Preferred Family Healthcare. So even though I'm employed by WashU, all my clinics are done through our rehab teen centers that are throughout Missouri, and you can see the different locations where we're at and give top quality psychiatric care along with the rehab outpatient and rehab residential units. And so one of the things I repeat both at the beginning and the end for those of you who need to do referrals for your patients is that Preferred is the one I know the best, and I'm at most of the different sites in Missouri. And so here is their number and the sites. I will list some other locations that are not Preferred at the end of this talk, so please stay tuned for those of you, especially if you're in Illinois. All right, let's start with a little bit of case presentation. This is a 16-year-old that presents to the emergency room with agitation and paranoia. He is actively responding to internal stimuli. He repeatedly says he needs to hide from the police that are trying to kill him. He has trouble answering your questions, but appears dazed at times, changes subjects quickly while responding. He complains of a headache at times and feeling dizzy. And there's also some psychomotor agitation or hyperactivity at times. You notice some tremor in his hands. The vital signs are here, little tachycardia, little elevated respiratory rate. You do notice conjunctival injection and fine tremor in his hands. Mom reports that he was found him hiding in his room with a knife in his hand, warning her not to let the police in the room. There is no previous history of any episodes like this before in this patient's history, and he actually was doing well at school and had been to soccer practice after school that day. So quite unusual. So a couple board style questions here. The first one being the most likely diagnosis at this point is, and I'll let you choose one, and you might want to pause this recording to choose your answer before I give you the answer. And that answer is actually most psychiatric ERs, and we'll give this patient the diagnosis A, psychotic disorder, NOS. We just don't have enough history or data to diagnose the other three. All the following drugs can cause psychotic disorder except, and pause it here if you want to think. It turns out all of these can cause psychotic disorder NOS except for B, or CBD, the cannabidiol, which is a non addictive component of cannabis that we'll talk about later. The others here are quite well known in case studies, especially emergency room presentations, to cause psychotic disorder, NOS. All right, as we found out more about this case, it turned out the soccer friend of a patient texts the mom while they're in the emergency room and says they tried Delta-8 gummies after practice. The patient told his friend he did not feel high from the 3 Delta-8 THC gummies that he had, so he took 5 more and then finally felt high and headed home, and that led to the psychotic episode. The UDS is positive for THC only, and turns out Delta-8 will cross will be also positive on a urine drug screen along with Delta-9, which is the more typical component in actual smoked weed. All right, here's how teenagers have been getting into Delta-8 weed. It's not only on TikToks, but it's in many stores around, well, you know, most Missouri towns have this in the grocery store. Usually the Delta-8's pretty low, but, well, CBD is more common. Delta-8, you probably do have to go to a more of a, like a head shop, as we used to call it in the days. Now, when do we have to start worrying about substance use in our teen clinics? Most studies over the years have shown us around the age of 12 to 13 is when most substance use kicks in, as you can see from this very old study, but still quite prominent. It's rare that I see someone under 12. I mean, there are a few, but they're usually cases of very extreme abuse or neglect. So most common teenagers you'll have in your practice, you'll need to probably start screening for around 12 to 13 years of age. In the DSM-4, we used to define terms such as abuse and dependence, and you'll still hear these terms used, you know, in non-medical areas. But in DSM-5, the medical areas chose to change these kind of pejorative terms to substance use disorders, which sounds a little less judgmental. We still use the words of addiction, of course, and we simplified it to just looking at 11 criteria and calling the substance use disorder mild, moderate, or severe based on how many of these criteria there are. And I simplified the 11 criteria here for you if you ever do want to figure out for a single patient where they're at in terms of substance use. But this makes it fairly common that most teens who are using most substances of abuse, such as alcohol, nicotine, cannabis, most of them will meet these criteria, at least for mild use disorder. And then the ones that we see in rehab are usually already into the moderate to severe level. Substance use really has moved into the mainstream, especially with the great availability of vapes, nicotine, and marijuana vapes. Very common now in this legalized era of marijuana, aka, and I'll say in quotes, medical marijuana. Cannabis is the most common substance use of dependence, just because it's does have THC, which can cause dependence, and most teens are going to use it daily if they get hooked on it. Whereas alcohol is the most common substance use of abuse in teens, and this is more of a binge pattern use in teens. Teens tend not to use alcohol daily. More common than most of the other psychiatric disorders, at least from some of the earlier epidemiology, and almost all kids with substance use disorders in the teen level will have some comorbidity. The ones I see mostly are the major depressive disorder and the anxiety disorders, such as generalized anxiety disorder, social anxiety, and PTSD. Autism spectrum and ADHD can also have their own unique risks and comorbidities with substance use disorder. Two that we see the most probably are cannabis use, in a rehab setting at least. Cannabis use disorder now known to have a 2 to 3-fold increase of schizophrenia, and alcohol use disorder known to have 3 to 4 increases of depression and suicide. So we do know that these comorbidities are very important, and we don't always know which comes first. Does the substance use lead to the psychiatric disorder, or does the psychiatric disorder predispose you to using drugs? And sometimes it can be hard to figure that out, but if you take a careful history, you can usually figure out that it can go both ways. Now, 15 is the mean age onset of substance use disorder from larger studies, and we do know that earlier someone starts substance use, the more likely they are going to have significant troubles with substance use disorders as an adult. One of the reasons we're very careful and have a lot of, the government puts a lot of money in towards teen rehab is because this is still a very sensitive part to the brain where a lot of the myelination of the frontal and prefrontal areas are occurring. And we think this goes on probably till around 23 to 24 years of age. And it's much more dangerous to use drugs during these developmental stages of the brain than it is in adulthood. Here are some of the addiction centers in the brain. You'll see not only the dopamine release and nucleus accumbens here in the center, but a lot of other structures are involved in not only the reward part of drugs, but also the addiction part, the part where your brain starts to say, I want to use this again, or I really loved how I feel, I'm going to use this again, I want to capture that feeling, or I want to get away from other things. And I would say for marijuana, especially, you're getting a lot of the prefrontal cortex where it's just kind of telling this part of the brain, oh, the world is fine. I don't have to think of my problems if I'm smoking weed. And that's can be a big relief for some teenagers who are going through a lot of mental health or history of trauma. All right, some of the substance use went up during COVID and the lockdown, and some went down. In general, we found that any socially cued drug use, like especially nicotine vape sharing in high school, went way down because teens weren't able to get access. A lot of teens don't own a vape, but if they meet a friend at school, they'll go ahead and hit it a couple times and get addicted to nicotine that way. Anything where boredom or psychiatric disorders were a cue for drug use went up, and marijuana showed this. Here's for alcohol use, as you can see, for 12 to 17-year-olds. Most used less alcohol compared to the other age groups because of the social aspect of alcohol use. Now let's switch to probably the one that we see the most for our admissions to rehab, which is cannabis use disorder. This is still, of course, illegal for teenagers in any state, and therefore can be, a lot of our teens are court-ordered, which is probably the best way to get a teen into rehab because a lot of them don't feel they need it. And here it shows a rapper from Hannibal using a good old joint. But here's what most teens use for their weed is they'll take an actual cigar, they'll take out the tobacco and they'll put in weed. So they're getting both nicotine from the wrapper as well as, the cigar wrapper, I should say, and weed inside. Some of the effects of weed, which you can counsel parents if they're not too savvy about what a weed-using teen is when they come home. They might have the giggles. They might have this conjunctival injections, probably the best one to teach parents about. What my patients say when they feel high is, I feel normal. I can fit in with my friends. It's my medicine, taps my creativity. So teenagers really think that, marijuana is just the miracle drug. And it can be hard for you as a clinician to counsel them as to the dangers. They might not believe you about the dangers or the need to quit. They might not want to go to rehab. We do have some, since we have some teenagers in residential rehab for 2 to 3 months, we get to see some of them have marijuana withdrawal symptoms. Here's the most common ones we see. I mean, most teenagers are not going to show any symptoms at all, but when they do, we see a lot of troubles with trouble eating, trouble sleeping, night sweats, and some other of these symptoms. Another board-style question here. ER visits for teens for marijuana intoxication have increased in recent years, mainly because, choose your answer here. And I would say when I originally wrote this question 7 years ago, I wanted it to be, the answer to be B, the THC content of marijuana has increased. But it turns out A can also be correct now, since states have begun to legalize marijuana. Teens are using more marijuana and getting more in trouble with intoxication symptoms and ending up in the ER. This is a graph that shows you how the potency of the THC in the average grown weed now has gone up from, well, it used to be as low as 4% back in the 60s and 70s, but now it's up to as high as, well, 14% in the most recent data I've been reading, sometimes 16 to 18%. So just the weed that growers grow has a lot more THC than it used to, and it's because they know that weed sells the best. And this is the weed that's probably totally untested in terms of medical marijuana, but is being called medical marijuana, where probably the most useful marijuana is the lower THC marijuana with good amounts of CBD. And the CBD is kind of protective in marijuana, and that has been bred out of marijuana. CBD kind of modulates THC and makes it sure it doesn't get too strong in the brain. Without the CBD around, the THC is much more addictive, and where we used to only have addiction rates of around 10% with marijuana, that's gone up to about 30 to 50% with not only smoked weed, but especially the dab carts, which I'm going to talk about here soon. So blunts are what most inner city St. Louis teens use the most, where they take a cigar, take out the tobacco, and put in the weed. Joints are very rarely used. Dabs, you'll find a few hobbyists that use this, but it's not as popular with the teens right now. What is most popular right now with especially my, for example, my suburban and rural teens is the dab carts, also THC pens. This is a vape, not unlike a nicotine vape, but it's filled with a concentrated THC juice that is around 60 to 90% THC, so a very high concentration. Gives them not only an intense buzz when they hit it, but is more likely to lead to addiction where they use a lot more than they plan to, and causes dysfunction, ER visits. Why do teens like this so much? Well, they can get away with it. They find that this doesn't let off as much of a smell as a blunt would or a bowl would, and they can wear. A lot of my teen females will tell me they can wear some heavy perfume and then hit this a couple times at high school, and teachers won't even know that they're using a THC vape. There's other convenience and the fact that some parents will see this and they just think it's a nicotine vape. There's other reasons they'll use it, because they can get away with it really well. So you might want to educate your parents about these vapes. Dab carts, as they say. All right. Here are some of the neurocognitive effects we know are well proven, not only short-term memory loss, but they can cause judgment, psychosis in rare cases, but especially in the edibles, paranoia, schizophrenia risk, depression, anxiety risk. All of these have been fairly well proven over the last 10 to 20 years. We also know it impairs driving, and if you combine alcohol and cannabis, they impair driving in different ways, so you get kind of a double whammy in terms of poor driving. We also know heavy use before 18 from this well-known study showed that it decreased IQ by at least 15 points. If you don't use weed heavily before 18 and then use heavily afterwards, it's less likely to cause that decrease in IQ. So another reason to discourage early use. There's also ER presentations, not only for lung conditions, but especially this cannabinoid hyperemesis syndrome can also be in teenagers, adults as well. And it's where you just have vomiting that just does not stop. And any typical thing that we might use, such as, IV fluids, dopamine antagonists, none of that decreases except for hot baths or capsaicin cream. So it seems that there is a receptor for heat on the skin that somehow shuts off this cycle. And this receptor seems to be hit by the THC and downregulated, and that leads to the hyperemesis syndrome over, especially for longer term daily users. So let's move on to some of the other products that you might find, especially in stores where you don't need a medical card, a green card to get these herbal preparations. CBD is the cannabidiol, which seems to be perhaps a more safer, useful form of the weed plant. You can also buy Delta 8 THC, which, as you can see, differs by Delta 9 just by the placement of this one double bond here. It's about 50% less potent than Delta 9 THC, but since it has slower absorption and longer sustained effect, teens can get in trouble because they tend to overuse it within the first 15 to 30 minutes because they don't feel it like they do the Delta 9. And that's what has led to problems. Here is the vote for recreational marijuana, which is now legal in Missouri. It was very close, but you can see the green yes votes came mostly from the bigger cities. Why do I worry about this for my teenagers? Well, every teenager now really thinks that weed's very safe because it's legal. And they'll even say things like, well, it's a lot safer than alcohol, which, if you look at the scientific literature, they probably got a point there. We just don't have as much scientific literature on the dangers of marijuana, but that most of the literature does show that marijuana is very dangerous. There is a new wave of marijuana being good research, but that's mostly supported by the big weed companies that are trying to put out the message that weed is safe. American Academy itself notes that they do not recommend the voting of the states for medical marijuana. They feel this right now is totally outside of FDA. And by the way, there are no FDA approved indications for medical marijuana. All the FDA indications for any kind of product that involves THC are where it's been purified and put into a pill form, or there's an analog to THC. And there it's only been FDA approved for oncology for a lot of the difficulties with eating that comes along with, and nausea and vomiting that comes along with cancer treatments. So really the medical marijuana, in quotes, for me, is the fact that it's not FDA approved for adults for any of the diagnoses that it's being used for. And we don't really have an evidence-based scientific basis for this use, even above the lack of FDA approval. So what does the AAP support? They support more research. They recommend changing marijuana from a drug Schedule 1 to a 2 to really facilitate a lot more studies so we can really get to the bottom of how safe or how dangerous is medical marijuana, what is the safest way to use it in terms of THC and CBD quantities. There's a lot of science pointing to the fact that we really do need lower THC and higher CBD in weed products to make them safer and more medically useful. But that's not what's being sold. All right, let's switch gears now to nicotine. And as you can see, smoking is safe. So a lot of teenagers also believe that vaping is safer than cigarettes, which has also not really been well proven. Nicotine vaping especially, is also way up. The 2019 results are here. As you can see, a huge increase in e-cigarettes, actually a decrease in actual cigarettes. because more teenagers would rather use the vapes. And this has gone up in 2020 and 2021. And the data hopefully should be out soon on those. And this is for high school, by the way. Let me show you the same study for middle school. And shockingly, a twofold increase in middle school vape use in 2019, right before the pandemic. And this is pretty race and ethnicity neutral in high school and middle school, as you can see from this study. Now, the most classic one that started out the vape craze for teenagers was the Juul, which they loved and used for about a year before teachers figured out these weren't USB drives. But once Juul, so once the government came in and said any of these fruity vapes like the mango was super popular, these were illegal in this kind of a vape cartridge, the Juul went out of popularity, because then you could only get a menthol or a tobacco flavor, with those tasted terrible when I asked my patients. And many different vapes have gone through popularity, but if I had to talk about the last couple months, here's the two most popular ones, and the ones you might want to ask your teen patients about if you see them today in the office. That would be the Alto Views, which has a pod here. This is a potted vape. So it only comes in tobacco and menthol due to the government laws now in America. But the teens like the menthol version of the Alto Views, so some will use that pod version. And it's very cheap. The most popular disposable vapes, these disposable vapes do not have any laws against them, against fruity flavors. So you can see all these fruity flavors that teens love. Los Marys are the ones that are most popular right now. So this one right here is pineapple mango, but all these are popular right now. It was ice bars just 2 months ago, so these things change pretty quick. So you might have to keep in touch and ask your teens what are their favorite vapes lately. But it is a really good way to break the ice. Sometimes if you just ask them if they're using any drugs, they'll say no. But if you say, hey, have you tried a Los Mary? I heard they taste pretty good. They're not only going to laugh, but they're going to say, yeah, I did try that last week. How did you know? So make sure you keep in touch with your teens on what they're using. Now, we do know that vapes have all the same components that are thought to be carcinogenic. This is an experiment still being done, since these may take 20 to 30 years before we start seeing the real cancer rates due to vapes, but we think it's going to be, maybe not as high as cigarette smoking, but pretty comparable. And there's other dangers to vape juices. A lot of this has been helped by the reduction of fruity vape juices, as well as more child safety packaging for any kind of vape liquid. For teens tend not to use these vape mods where you add the actual juice to it. They tend to like the cartridge vapes or the disposable vapes where they just throw it away once it's done. EVALI was a big thing when dab carts first came out, the THC vapes, because a lot of the illegal dab carts were being cut with vitamin E acetate, and when you burn that, that leads to the specific EVALI lung injury, and this peaked in late 2019, early 2020, and has gone away. One of the benefits of medical marijuana is that the dab carts around are well controlled, regulated, at least for the most part, and they teens tend to have less troubles with at least EVALI lately. Now, I could spend a lot of time talking about other addictions in adolescents, but in the interest of time, I can't talk about all of these. Thankfully, opioid abuse and the fentanyl crisis has been fairly rare amongst teenagers. I still get 5 to 10 patients in the different residential rehabs a year where we do have to treat them for opiate use disorder, but thankfully it's a smaller percentage than what we see in adults. Methamphetamine has gone down in general than it was 5 to 10 years ago. Occasionally we'll see stimulant users, so Adderall perhaps is the most popular Adderall XR. They'll crush it and snort it. Most of those are not people with ADHD, so please do not stop prescribing stimulants for your elementary school students and teenagers with, who need a stimulant for effective control of it. And even if your patient becomes a cannabis smoker, you don't necessarily have to stop stimulants. That's not an absolute contraindication as long as the medicines are controlled well by the parents. And there's some evidence that they're not using the weed daily, you should be okay. And we don't have enough evidence base yet to say, does weed interfere with the use of stimulants or not? I mean, I do have some patients that have used both at the same time and done just fine. But in general, it's a tough clinical call right now. So use your best judgment in those. Dextromethorphan can be, and other cough medicines can be abused, but it's pretty rare. And finally, we do have a lot of these, we have a lot of concern these days about video games, social media, smartphone addictions. All of these are being discussed as perhaps contributing to some of the pandemic in psychiatric disorders in teenagers. No good proof yet for any of them, but I would agree that they are, for the most part, addictive for teenagers and harmful for teen brains. So AAP recommends universal screening of adolescents for tobacco, alcohol, and other drug use by using which of the following screening tools? And as many of you know, the answer is A, the SBIRT, or Screening Brief Intervention and Referral to Treatment. That's a quite popular, very well documented over the last couple decades by the AAP. Most practices I've talked to say they maybe use this screening with a few documents that are filled out for the first time. But most tend to not have enough time to do this at every adolescent visit, especially an acute visit. So you might want to figure out how it fits into your practice. Here's the original adolescent SBIRT algorithm from 10 years ago, but it's still recommended. It is encouraged at every visit, especially in the adolescent years. I would say starting at around 12 to 13 would be good for your clinic. It involves these 3 questions, which can either be asked in person or as a screener. If you drank any alcohol, smoked any marijuana, used anything else to get high. I find if you're in person, these tend to get a little more honest answers if you're alone with a teen. It can be very hard sometimes to get the patient alone without one or both parents. So if you can, you're going to get more honest answers to this. And then I'll see if it's a form that's filled out. Teens will tend to lie about these as well. If you do get answers here, there's the Kraft scores, and these can tell you whether or not you just need to praise your patient for staying off of drugs, or for maybe some protective maintenance advice, such as contracts for safe driving. You can go online and fill out a contract with your parent that they will come and pick you up if you feel you are not safe to drive, and not give you consequences for getting drunk at a party. There's moderate risk. You can also counsel the patient about some of the dangers. If there's higher risks, you want to consider about referral. And one of them, of course, is a referral to preferred family health care. The unfortunate thing is that teenagers got to want to come as well, which doesn't always seem to be true. Although I've had some parents that have been able to convince their teenager that they really do need to at least go to an outpatient treatment. But the most common reasons we have kids in rehab is either the high school has required it because they got caught with drugs on campus for high schools, or they've got in trouble with the law, and then the law says you're either going to jail or rehab, and most teenagers will choose the rehab. All right, so the practical steps from all of this is, once again, trying to interview the adolescent without the parents around, taking these names that I've told you about, trendy vapes or dab carts, and just mentioning those in passing and seeing if that helps your teen talk about their actual, and be truthful about their use. And then I find another way to bring this up is actually, before talking about drugs, is to say something like, hey, do you think you've been addicted to your smartphone lately? Do you use TikTok too much, or whatever the favorite app is this summer? And usually that gets the teen in a state where they know you're not only lighthearted, but you're going to be gentle about it. You're not going to be judgmental, and you're going to get some more honest answers. Here's some of the treatments, therapies that we use in the rehab setting. A lot of combination of motivational interviewing and therapeutic community are probably the two techniques we use the most. Obviously, you won't be able to recreate this in your clinics in the primary care setting, but probably one thing you could recreate if you wanted to would be urine drug screens. And I also told parents about a Dollar Tree does have a $1, or what I think it's $1.25 now, cannabis urine drug screen that they can also use at home. Other things that we use in rehab, we use a little bit of medications for teen substance use, but it's not really our go-to. But here's some of the medications that we use. So feel free to ask me any questions about these. And I'll give you some of the ways to ask me questions here soon. For those of you who do know about opiate epidemic in adults, we use a lot of Narcan nasal spray now. And this does thankfully help recover a lot of people who have overdosed on fentanyl, usually unknowingly. Usually they'll get just a batch of fentanyl that's stronger than the batch before, use what they thought they were going to normally use to get high, and it's way too strong for them, and then they end up overdosing. And this has saved several of my teen patients have died several times and come back to life thanks to Narcan. So here's once again the name and the number for rehab. You can also find it online if there's a site near you that you want to call. Here are some of the other places with some level of teen substance use support. In Illinois, you might want to check with Chestnut or Gateway. And there's some other links for the AAP and SAMHSA if you want to get resources for parents you want to print out, or updates for any policy statements. And probably the best way, if you do have a question after listening to this, would be to email me at my WashU email, which is Paul Glazer with no dot in the middle at wustl.edu. And I usually can get back to questions within a few days. All right, thank you for your attention, and hope this helps you in your clinics.